Good afternoon, everyone. We are back to our internal meeting of scientific in this new year 2022. But again, we are starting up with another very important session of this year, which we are coming across COVID pandemic once again with a new variant, Omicron variant. We all are curious to know how this Omicron variant is going to, either it is going to help us or it is going to be once again a disaster. So we want a scientific evidence for this Omicron. So we have called upon some experts for on this to know about this Omicron variant and its behavior in our in the forthcoming days. So we So we have organized this session on Omicron facts and figures. We'd like to know with this session. And previously we had two sessions on COVID management, which had helped us a lot in the patient care services, which has improved a lot after the scientific sessions we had in the last year. So with this, I'll welcome our dean, beloved dean, Professor P.F. Kotu sir, our dynamic dean HPE, Dr. V.N. Mahalakshmi madam, our medical superintendent, Dr. K. Jayasingh, and the medicine HOD, Dr. Vidyavati. She couldn't join with us. Both have consent to chair the session today, and our director medical research, Dr. Vishnubat, and all the heads of all the departments, the faculty, and the resource persons who have readily accepted to have their expert ideas with us, the postgraduates, the interns, and other all the members who have all the participants of this today's scientific session. With this, I'd like to invite our member secretary, Dr. N. Nishantini, to read the report on the previous meetings. Dr. Nishantini, please.
She seems to be incognito.
Yeah, ma'am. There is some problem with her internet, it seems. So let me go ahead with the report, ma'am. So we
Yeah.
had a second annual endowment oration of Rtpcr Medical College, the external oration. It was instituted. It is instituted in the name of founder chancellor Dr. A.
Same
Shanmugasundaram.
to
It was conducted at Srimati Annapurni Shanmugasundaram Multipurpose Auditorium, AVMC, at 2:30 p.m. in physical mode on 23/12/2021. Dr. A. Shanmugasundaram Endowment Oration was awarded to Professor Gurmeet Singh, Honorable Vice Chancellor, Pondicherry Central University. The program commenced with a welcome address by Professor P.F. Kotu, Dean AVMCH. Professor V.N. Mahalakshmi, Dean Health Professions Education, AVMCH, introduced the oration to the audience. Professor K. Jayasingh, Medical Superintendent, shared the Chancellor's message with the audience. Professor Vishnu Bhatt, Director Medical Research and Professor of Pediatrics and Neonatology, introduced the orator, Professor Gurmeet Singh, and shared the contents of citation. The orator, Professor Gurmeet Singh, was presented with the citation and medal during the grand academic event. The second annual endowment oration was delivered by him on the importance of optimization of health higher education with special reference to medical education. The orator highlighted the positive aspects of medical education in India. He encouraged the young budding doctors and appreciated the selfless service rendered by the medical fraternity in India, especially during this pandemic. In this proud occasion, the annual calendar of events 2022 was released by the hands of the orator. Professor S. Deepa, President Scientific, proposed the vote of thanks. The program ended with national anthem. Also, I would like to present the report on 20th Internal Meeting of Scientific, which was conducted on 28/10/2021 at 2:30 p.m. through Cisco WebEx platform. The program commenced with the welcome address by the President Scientific, Dr. P. Uday Kumar. followed by the reports on the previous meetings by Dr. S. Deepa, Member Secretary. An interesting video on recent advances and innovations in healthcare was presented by Dr. V. N. Mahalakshmi, Dean HP. The scientific session of the meeting was dedicated to the original research work conducted at AVMC, and it was chaired by Dr. Vishnu Bhatt, Director Medical Research. A review of Supreme Court judgments on criminal negligence cases was between 2011 to 2022 was presented by Dr. A. Arti from Forensic Medicine. Dr. M. Arti from Center for Biomedical Research shared her research on atrial fibrillation risk variant RS 2200733 in Indian young adult population. Mr. N. Prabhudas, PhD scholar from Center for Biomedical Research, presented his research paper on role of non-invasive serum biomarkers for the diagnosis of liver cirrhosis. A study on clinical course of asymptomatic and mildly symptomatic COVID-19 positive patients was presented by Dr. Sajjan Prasad RMO. The scientific session was interesting and enriching with the queries from audience being addressed. The program ended with vote of thanks. With this, we'll go ahead with the next on a Mediquiz on Omicron. It will be shared by our executive member, Dr. Sri Lakshmi.
If we need to join using Mentimeter, code is there on the screen.
Code is not visible properly, ma'am. Dr. Sri Lakshmi, can you tell the code again for, or you can copy it, put it in the chat box also, the code.
Code to join is 11692897. I repeat.
Yeah, the link is shared in the chat box also. And the code is also put up in the chat box. One. All of you, please open www.menti.com and you have to enter the code.
If my screen is visible?
Yeah, ma'am, your screen is visible, ma'am. The top of the screen was covered by viewing scientific AVMC screen. So we were not able to see the code, ma'am. Otherwise, it is visible only, ma'am. The questions are question 1 out of 10. The center part is visible very clearly.
We have 12 people who have joined so far. We'd encourage all the participants to join the quiz. We have 21 people who have joined, 22. So we'll start the quiz, Deepa. Okay, 24.
Okay, ma'am.
Starting the first question now. This is question number 1. Please look at your phone.
Not for Googling.
Okay. 19 people got it right. The answer is 26th of November 2021. Lakshmi, you want to add anything?
WHO has declared Omicron as variant of concern based on the functional definition for variant of concern being increase in transmissibility, increase in virulence of the organism, and decrease in effectiveness of public health care. So, any of these three things will contribute the organism to become the variant of concern from the variant of interest.
Okay, next question coming up. Please look into your phone. You have 20 seconds to answer. Explanation.
Loss of S gene or the dropout of S gene is considered as a differentiating feature for Omicron in the Rtpcr investigation compared to other variants we have seen so far. So, but the confirmation will always be the genomic study.
Okay, next question. You need to be fast with your fingers to get the best scores. Please look into your phone. Explanation.
The doubling time for Omicron is observed to be 2 to 3 days in the countries where it has already tided over the wave. So, from studies of related to Omicron, from UK and South Africa, the doubling time of Omicron is observed to be 2 to 3 days.
Okay, next question. Be fast. Please look into your phone. Explanation.
So, as we all know, Omicron has multiple mutations. To 17 mutations have been found out. Out of which, the spike protein mutation itself is 36. So, that is the reason for high transmissibility of this virus. And the key changes of S gene, mainly in the receptor binding domain, furin cleavage site, and NTD antigenic supersite. These three key regions of S gene contribute to multiple increased transmissibility of the virus. The source of this information is a study conducted by JAMA in South Africa related to outcomes of COVID-19 during the Omicron wave they had. So they have found the death rate to be 2.7% compared to the older Delta wave which had 29.1%. So we presume that we will also have various virulent waves. We'll wind up the quiz session here.
Dr. Anu is leading. Explanation.
WHO has recommended two new drugs, baricitinib and satrovimab. So both are approved in December 2020, 2021, and baricitinib is already started included in the COVID treatment protocol by the CMC level. But we have to use the drug to know the better efficacy of it.
Explanation.
Molnupiravir is a nucleoside analog that is used in treatment of patients with moderate COVID in the Omicron wave. It is approved for use in India, but it has not been included by the National COVID Task Force by AIMS and ICMR.
कोणता चांगला आहे
Nirmatrelvir and ritonavir both are the protease inhibitors that prevents viral replication. And ritonavir is boosted with nirmatrelvir to enhance the systemic availability of the drug. The UK Health Security Agency and the NHS data has provided data that after 2 doses of Covishield, only 3% protectivity is there for against Omicron variant, which is 36 times lower than the previous Delta variant. So they have also found that when a booster dose is given, the efficacy will increase up to 73%. Varicetinin is approved by WHO from July 2021, but it is of use now only. So it is a Janus kinase inhibitor, which usually is used again in rheumatoid arthritis and all to suppress overstimulation of the immune system.
Final scores. Congratulations, Dr. Anu. Over to you, Dr. Deepa. Dr. Deepa? Okay. Let's move on to an interesting video, a TED Talk on Omicron variant, how this COVID-19 has changed the face of healthcare, right? Till Dr. Deepa joins.
As a small child, I was lucky to be at the launch of Apollo 17, the last manned mission to the moon. And I've remained enamored with space ever since, and fortunate as a physician to have contributed to NASA life sciences research and to practice aerospace medicine, inspired by the cross-disciplinary teamwork required to tackle audacious challenges, and how space has often brought the world together through the lens of seeing our planet as one without borders. Now, just as the historic Apollo moon landings were transformational inflection points in history, so too is the global health crisis of COVID-19, which, despite its many challenges and tragedies, like the sinister Cold War setting which launched the space race, can have silver linings. As Regina Dugan, former head of DARPA, wrote, "Sputnik set off the space age, COVID can spark the health age." The silver linings include the unprecedented acceleration of innovation, collaboration, and discovery, catalyzing a future of health and medicine that can help us reimagine and bring us a healthier, smarter, more equitable post-COVID world. Now, many solutions ride the rails of rapidly or exponentially developing technologies that are rapidly doubling in their speed, price, performance, as exemplified by Moore's Law, which has enabled the billion-fold improvements in memory and computation, resulting in the ubiquitous supercomputer smartphones most of us carry in our pockets. I still have my now ancient iPhone 2 here. Still works, which felt magical 12 years ago, but now feels slow and kludgy. I'm sure my iPhone 11 will soon seem antique, perhaps as its features dissolve into the rumored to soon arrive augmented reality smart glasses. Now, exponential technologies packed into our smart devices are becoming increasingly medicalized. Their sensors able to detect an ear infection and more. So what used to fit on a desktop computer now fits on our wrist, and these are now entering the domain of FDA-approved medical devices. But the future isn't about any one technology, but their convergence as they get faster, cheaper, better, in fact, creating entire new fields at their interfaces, from computational biology, robotic surgery, digiceuticals, telemedicine, to AI-enabled radiology. And while many industries have been disrupted and reached the fourth industrial age, health and medicine often feels stuck in the second or third. Critical data is still stuck being shared on fax machines, paper forms. We're stuck in waiting rooms, waiting for our visits. I recently had my own echocardiogram only made available to share with me on a CD-ROM. I don't even own a CD-ROM player anymore. Tools for managing pandemics of 2020 rely on the same core technologies used in the pandemic of 1918, face masks, social distancing, hand washing. So part of the challenge in advancing global and local health are our models and our mindsets. We don't really practice healthcare, we practice sick care. Sick care is based on intermittent episodic data, usually only obtained within the four walls of the clinic or hospital bed, and leads to our reactive sick care model where we wait for the patient to show up in the emergency room with a heart attack, stroke, or late-stage cancer, or for the pandemic to arrive on our shores. I believe the convergence of many of the accelerating technologies and approaches being catalyzed by COVID will bring us from intermittent sick care to an age of continuous, proactive, personalized, crowdsourced healthcare that can increasingly bring care anytime, anywhere, more effectively and lower costs around the planet. For example, the convergence of ever smaller interconnected devices now riding 5G is creating not just an Internet of Things, but an Internet of medical things. Much of this convergence is in the field of digital health, the ability to connect the dots between data sources for personal genomics and medical records with apps and services that match the needs of an individual patient or caregiver. And as incentives and reimbursements align, COVID has pushed us to an increasingly virtualized care, from the hospital to home to our phone to on and even inside our bodies. The age of hospital to hospital is upon us. Now, the challenge of this hyper-connected age is that we're creating exponential amounts of big data that's too often siloed in formats that can't even talk to each other. So we need to narrow that gap between data, turning that into actionable information for the patient, physician, public health worker, and speed its safe and effective use in the community, clinic, and bedside. The pandemic has instigated an immense amount of international sharing and collaboration amongst clinicians and researchers to narrow that gap. What was learned in managing patients in Wuhan and then in the intensive care units of Italy have helped New York City hospitals, and their learnings in turn have spread to centers around the world. Let's take a quick dive into some examples of what's happening across the healthcare paradigm in the age of COVID and their implications for the future. From new forms of data to health prediction and prevention, to faster diagnostics, more tailored therapy, and increasingly crowdsourced discovery. Let's start with prevention. While our genomes impact our health outcomes and our health spans, our social determinants of health, our sociome, and our day-to-day behaviors drive most of our risk for disease and associated costs. And we now have an explosion of new tools to help measure and improve our healthy behaviors. The first Fitbit only launched in 2009. Wearables are now ubiquitous and can measure almost every element of our physiology, behavior, and even mental health. And they're evolving all the way from disposable tattoos that can stream vital signs 24/7 to an integration of big data that can even be small data from a simple wearable tracking a patient discharged home after a hip replacement or a coronavirus infection can determine if the patient's recovering as expected, walking more, doing great, or not so great, and trigger early intervention. We're evolving from a world of quantified self, where our digital data remains siloed on our devices, to one of quantified health, where the data can be shared securely with clinical teams and researchers to help optimize prevention, diagnose disease early, and with feedback loops, personalize and optimize therapy. From wristband vitals, including blood pressure, now obtainable without a cuff, and soon sensors that will measure our blood oxygenation levels, to continuous blood sugar monitoring, to shockables, hearables, ringables that can replace an entire sleep lab fitting on our finger, to insidables, chips beneath our skin to track our physiology and lab values, to even underwearables, Internet of Medical Things sensors so cheap today, you can get a pack of 10 of them and have one in each band of your underwear, now being used to do what's called remote patient monitoring to help detect signs of respiratory decompensation in patients with bronchitis or COVID. Breathables are showing promise, nano noses that can detect molecules in our breath, correlating to cancer, metabolic disease, and even diagnosing infectious disease. In fact, we now don't need to wear anything. Invisibles, ambient sensing from AI-enabled cameras can track our vital signs. To voice as a biomarker to manage and detect mental health challenges, signs of heart disease, now being able to differentiate between a cough from a common cold to that one caused by coronavirus. And we'll soon be exuding our digital exhaust 24/7, our digitome, How can we make sense and truly leverage it? One path is through crowdsourcing. The million-participant All of Us trial from the National Institutes of Health is doing just that, where data donors, and I'm one, can contribute our medical records, genomes, and wearable data to build a much better and diverse data set crossing racial and socioeconomic groups to help foster better precision medicine for all of us. Integrating this information for the individual and public health will lead to predictalytics, our own personal check engine lights that can give us early proactive warning. And recent work is demonstrating that wearables can detect pre-symptomatically the onset of the flu, or as recently published by Stanford, in 83% of COVID patients, smartwatches can detect COVID infections early, often days before onset of symptoms. Self-reporting websites like COVID Near You enable us to locally generate infections maps, and combined with our social graphs and contact tracing apps, may provide us detailed suggestions about who we might want to consider being near or socially distanced from. What about advancements in diagnostics and monitoring? What used to require a full clinic or laboratory can now fit into a digital doctor's bag or the pocket of a patient. From COVID quarantine kits enabling tracking of oxygen saturation, temperature, and lung sounds, we're starting to integrate these into virtual visits, providing real-time enhancements of a virtual physical exam. And the diagnostic tools are becoming increasingly infused with AI machine learning, including consumer ultrasounds, which can bring diagnostics anywhere at very low cost, including the ability to evaluate the lungs in suspected COVID patients. The laboratory has shrunk to microfluidic platforms that can be attached to our smartphones and enable anyone to obtain measurements from blood or saliva. Many of these diagnostics are leveraging the smartphone and its camera for a medical selfie. For example, instead of taking your urine to the lab to diagnose a potential urinary tract infection, in the privacy of your home, simply dip the urine dipstick, take a picture with your smartphone camera, and have the results made available immediately to your doctor and pharmacy. Similar phone-based apps and approaches are being used and developed for fast, frequent, cheap, and easy COVID testing. Novel approaches to community-level diagnostics are also being explored, including next-gen sequencing of sewage for early detection of COVID-19, identifying hotspots and predicted outbreaks a week or more early. The explosion of data sources, however, is really beyond the capacity of the human mind to effectively integrate. We're now getting help from AI, or as I call it, IA, intelligence augmentation. IA is being leveraged in reading CT scans to diagnose COVID, to enhancing the vision of a gastroenterologist performing a colonoscopy, to identify lesions they might have missed. And AI is playing an active role in helping identify and develop new antivirals. And while AI is often perceived as a threat by some clinicians, it can't replace the human touch or empathy. And I don't think doctors or nurses will be replaced by AI, but doctors and healthcare systems work collaboratively with AI in the future will be replacing those who don't. Finally, therapy. The pandemic has dramatically accelerated the use of virtual visits. Telemedicine visits are up on the order of 1,000% in many settings, and I don't think we'll ever revert to pre-COVID levels, as patients and clinicians are discovering the compelling convenience and efficacy. Even before virtual Zoom or FaceTime with a clinician, asynchronous screening and support is being provided by ever smarter chatbots that can help discern symptoms and help triage problems effectively at lower cost. This includes virtualization and virtual augmentation to meet our mental health crisis, exacerbated by the many economic and other stressors which accompany this pandemic. 3D printing is finding a role in healthcare, with newfound applications from printing personal masks to critical parts of ventilators, and being leveraged by the growing make movement, which is playing a major role in pandemic response, from making face shields and masks to improvising do-it-yourself ventilators. Altogether, these efforts are enabling the potential for democratization of health and medicine across the planet and access to information and care that was previously inaccessible. Clinical trials are being reshaped, leveraging smart devices, cloud-based analytic platforms, and collaborators around the world. It's at this convergence of many rapid developing and exponential technologies that we have the real potential to reshape and scale healthcare in our pandemic age. One where we can dramatically expand access to basic healthcare, increasingly personalized and proactive, leveraging the scale of digital platforms and technologies, enhancing digital connection and empathy and the ability to blend virtual and in-person care, and leveraging the power of the crowd to share and build better maps that guide our individual health and public health journeys and to develop validated and scaled solutions. So imagine a new generation of volunteers, a global health corps, similar to the volunteer paramedics and firemen of today, that can be upskilled, use the powerful new tools to respond early and collectively to enhance contact tracing, isolation, and quarantine, and to help identify and address social and other disparities. So coming full circle, 24 years after I was at the launch of Apollo 17, I found myself as a medical student on a research clerkship at Johnson Space Center. And much to my surprise, one day in the clinic, I ran right into Gene Cernan, the Apollo 17 commander and the last man to walk on the moon. After enthusiastically sharing my childhood memories of his launch, he shared one of his famous lines, "I walked on the moon, what can't you do?" Indeed, what can't we do if we work together as one in the face of this pandemic? And just as the near tragedy of Apollo 13 rallied NASA to work creatively and collectively, so too can this, in our pandemic age, lead to our finest hour and bring on a true health age. I believe this is possible if we all get out of our linear mindsets, take exponential steps, and collaboratively go forth collectively, not only to solve the challenges of this pandemic and predict the future of health and medicine, but boldly to go forth together to accelerate a far better one for everyone on Spaceship Earth. Thanks.
Over to you, Deepa.
Thank you, ma'am. Thank you, ma'am, for a nice video on IoT, Internet of Things. I was wondering, without Internet of Things, how we would have gone across this pandemic. Ma'am, you are able to hear me?
I'm able to hear, madam. Dr. Deepa, I'm able to hear.
Hi. Oh, okay. Okay, sir. Okay, sir. Thanks to Internet of Things, sir is able to hear. He's telling, ma'am.
Your audio
Deepa, we are
headset is
able to
not
hear
working.
you.
Okay, ma'am. Thanks to this Internet of Things, we were able to tide over this crisis of till now this COVID. Thanks to this, we were able to do teleconsultation and wide variety of things. As well. So the entire medical fraternity was pushed towards going towards implementing this Internet of Medical Things. Soon we'll be having this electronic medical records and other things. Thanks for that nice video, ma'am, once again. Now we'll go ahead with the scientific session today on Omicron, facts and figures. So we would like to invite our medical superintendent, Dr. K. Jai Singh, and Professor of General Medicine to chair this session. Sir has been the has guided us through first wave and second wave, and we are into the third wave with hope so with many of Omicron cases. Still, we don't know what are the type of COVID positivity we are getting in our institute or outside also. So it would be thank you, sir, for accepting to be the chairperson for this session. And unfortunately, Vidyavati madam, she could not chair today, but thanks to madam also who have consented to chair. And we have three speakers today, and we'll start with the clinical presentation by our professor from pulmonary medicine and other followed by the other speakers. Already the guidelines I have sent to all the speaker, to the resource person. You'll be given 15 minutes for your presentation, and at the end of all the session, we'll be able to take up the queries. And I request all the participants to put forth the queries in the chat box. Sir, Dr. Jai Singh, sir, over to you, sir. The screen is yours.
Thank you, Dr. Deepa. Respected Dean and patron of the Scientific Society, Dr. Kotur, advisor and Dean HP, Dr. Mahalashmi, President of the Scientific Society, Dr. Deepa, Vice President, Dr. Ariel Rajan, Secretary and one of the speakers of today, Dr. Nishantini, executive members, speakers of the day, Dr. Setu Mathavan, Dr. Madan Raj, and other enthusiastic participants of today's 21st internal meeting of Scientific. Good evening to all. I thank the team Scientific for giving me this opportunity to chair the scientific session on Omicron, facts and figures. The COVID-19 surge continues to sweep across India, driven by Omicron variant. India so far has reported 282,970 new cases on 19/1/2022, that is yesterday. India reported new cases around 18.9% higher than 18/1/2022. There are 19,24,051 active cases at present in India. Recoveries in the last 24 hours is 2,23,990. Daily positive rate is 16.41. As far as the Pondicherry is concerned, 1,849 cases were reported to be COVID positive on yesterday, that is 19/1/2022. So far, 1,42,559 persons have been affected with COVID in Pondicherry. Now, 11,217 cases are under home isolation in Pondicherry. Of course, this appeared as a question in the quiz program also. On 26th November 2021, WHO designated the variant B 1.1.529 as a variant of concern and named it as Omicron. As far as the transmissibility is concerned, it is not yet clear whether Omicron is more transmissible compared to other variants, including the Delta virus. It is also not clear whether infection with Omicron causes more severe disease compared to infection with other variants, including Delta. There is currently no information to suggest that symptoms associated with Omicron are different from those from other variant. All variants of COVID-19, including Delta variant, that is dominant worldwide, can cause severe disease or even death, in particular for most vulnerable population, and hence prevention is always the key. Here with us today is Dr. Madan Raj, Professor, Pulmonary Medicine, to share his vast knowledge about the clinical presentation and management about Omicron. I call upon Dr. Madan Raj to give his talk on this important topic. Over to Dr. Madan Raj.
Thank you, sir. Okay. The slide is visible, sir.
Yes,
Slide
yes,
is-
yes.
Okay. Good afternoon, respected Dean sir, Dean HP ma'am, MS sir, and all the other executive members of the scientific. At the outset, I'd like to thank the scientific for giving me this opportunity. And it's been literally years, and this is probably the third year which we have been speaking about COVID. Okay, we started in 2020, and it's like a sudden new entry now. It has become a used one. Now COVID is literally a household name, a WhatsApp addict, it's a part of any business. Okay, pre-COVID business, post-COVID business. Now a lot of share markets are being changed with the whether the third wave will affect the share market or not, and availability of beds. And every exam forthcoming in next February, March will have at least a long answer with COVID, short answer with COVID, and Viva with COVID. Without COVID, it's not going to get completed starting from the first year to the final year. And of course, for PG, COVID is going to be their long answer. Uh, and any patient who walks into the hospital or comes into the clinic is COVID unless otherwise proved. It has come to that level. So it's getting really difficult to see people who are either normal or people who don't have any symptoms. We have been pushed to that level. And okay, good afternoon to everyone. So given the 15 minutes of my time, I'll try to go through the basics of a Omicron variant. Some clinical features management more or less is the same like Delta, and it is most of us know the basic clinical features in the management. And the Triage protocol will be a short revision because it will be helpful for the upcoming third wave, so that we'll be able to manage the patients better. And this was 10 days back when I started preparing for the slide. So there are more than 3 crore cases, and we had around 54 lakh deaths. Okay. So, and in the 10 days, it has increased by high numbers. And we had recently seen our, just now MSR had given the Indian data of more than 20 lakh Omicron cases as of now. I think the other speakers will be able to give much more data on that. I'll just skip to what is exactly the variant of concern today, which is Omicron. So what people have been saying about variant of concern and variant of interest. So I'll just give a two to three lines basically about what is variant of interest and variant of concern. All of us know that on November 26, the variant of concern, which is the Omicron, was actually named. There are three important parameters which have to be looked around. One is the virus transmissibility. One is the disease severity. How bad is the virus producing the disease, the new variant? And how effective are our existing vaccines and the diagnostic tools in detecting the new variant? Based on these three parameters only, the WHO is characterizing the each and every variant into a variant of interest and then or into a variant of concern. As I already told you, there are only three key properties. One is the transmissibility of the virus, its virulence, it could be high virulent or low virulent, and its ability to evade immune responses. Basically, whether the available existing diagnostic tools can detect the virus or the drugs can treat the disease. So what is about variant of interest is because variant of interest is mostly for the scientific community to see whether new variants are coming, how the virus is changing over a period of time, what are the new types of mutations which are happening. But when it has a specific parameters, that is when there is increase in transmissibility. So when there is higher in why Omicron is becoming a variant of concern, because it is having an increasing in transmissibility. So there is a higher transmission compared to Delta. When there is a change in virulence, so most of the studies have shown that Omicron is slightly lesser virulent than Delta, but still we are at the primitive stage. We are yet to officially conclude that statement saying that Omicron is less virulent than Delta, but the earlier studies or the primitive studies are showing it is slightly lesser in virulence. But as of now, almost all the available tests can diagnose Omicron as well as Delta. So the increasing transmissibility and the change in virulence had made WHO to name Omicron from a variant of interest to variant of concern. So what exactly is an Omicron? It's a new variant which is being told on 26 November. Then a lot of talks have been already done about that. So I'll just directly go. This is the microbiological part, I think, which will be dealt in the subsequent talk, but I'll still give a small gist. Omicron spike protein has 26 amino acid mutations. Compared to Delta, there are only 7 mutations. Beta, there are 6 mutations, and go on. So a lot of mutations are there in the spike protein. Because of the mutation, the spike protein, Omicron is none of the existing vaccines which mostly targets a spike protein, is as efficacious as Omicron variant compared to Delta variant. Most of the vaccines which are present today are very good against Delta, but not as effective for Omicron because of the mutation in the spike protein. So this is what I was saying. Is Omicron variant more severe than the existing variants? So the primitive data, what we say that it is mild or less severe compared to Delta, but it is a very, very, very early stage because it's only 2 months old from November 26 to January 26. We are still yet to get more numbers from all over the world, and WHO has still given us only a caution. So still we'll be keeping it as a importance same as Delta, and we'll be treating every COVID Omicron case as like a Delta case, and we'll have to be careful regarding the transmission. So what we know about Omicron? Omicron is still more transmissible compared to Delta. And what is more important is that people who have been infected with Delta, people who had been vaccinated earlier, still get infected with Omicron. And the second thing is, people who had been already infected with Omicron, are they getting reinfected? It's still a question. There are yet to have complete data. I think only 1 or 2 cases of Omicron reinfections has been reported. But as of now, what is sure is that people who have been infected with Delta variant and the other existing COVID variants are susceptible to Omicron variant like people who have not been exposed, which means everybody who has been infected in the first wave or third wave are not infected, or same as anybody who has not been infected. Everybody will get Omicron in the forthcoming weeks or months if they don't follow the standard protocols of mask, safe distancing, and even if you're vaccinated, you may still get the disease. Coming to detection, most of the standard tests what we have, including the rapid antigen test and Rtpcr, can detect Omicron variant. But whether to say it is Omicron variant or not, we'll have to do genomic studies with the spike proteins and the other genes to confirm the Omicron, which is it's a longer thing. So as of now, what we use is a common antigen test and common Rtpcr test to detect the presence of COVID virus. Clinical management will separately. Okay, this is what we know as per the latest data. Omicron causes lesser death compared to Delta, as the quiz has already shown. The death in Omicron was only 2% compared to Delta. It was slightly around 20% in that particular study. Similarly, overall, if you take Delta has around 4 to 5% death, whereas Omicron is 1 to 2%. So Omicron, as of now, has a much lower death rate. The predominant symptoms are more or less same for Omicron Delta, whereas the difference is being the common symptoms are very simple. Any airways, upper airway symptoms like running nose, headache, fever, sore throat, myalgia, plus minus abdominal symptoms like a diarrhea or dyspepsia, and low grade fever too. Some patients still have high grade fever. This is same for most of the Omicron or Delta cases. In Delta, we had a lot of patients having loss of taste and smell, whereas in Omicron, it is slightly on the low range. Again, not all patients need not manifest all the symptoms. Some patients may have 2 or 3 symptoms, some patients may have 4 or 5 symptoms. So normally the symptoms last for 4 to 5 days. By the end of first week, most of the symptoms resolves in most patients, and less than 1 or 2% patients only has symptoms beyond the first week. And the patients who have symptoms for a longer week, mostly it is related with the fatigue, tiredness, and joint pains. Okay, so because, and the next thing, there is a low inflammation in lungs, so low incidence of pneumonia in Omicron compared to Delta, indirectly saying low risk of death. And because there is a change in spike protein, neutralization by antibodies is not possible in Omicron, and there is an insertion mutation in Omicron, so it has a higher transmissibility compared to Delta. So this is a rare cases of Omicron rash, which is seen in the fingers and the legs, which were presented from South Africa. As of now, I have not seen any case, and my friends, when I discussed also in our groups, in the pulmonology groups, we have not seen much skin lesions in patients with COVID. But these are all some rare features which have been reported from South Africa. So about vaccinations, what I would like to, I think that's a different topic. So if a patient has been already infected with COVID, still he is likely and liable to get another infection. So about vaccines, there'll be a separate talk. So just skip this. This is the basically a triage protocol. Anybody comes to you with the Rtpcr COVID test, he is positive, he is symptomatic, and we'll have to classify based on the respiratory rate and the saturation. If the oxygen saturation is more than 94, respiratory rate less than 24, he or it is normal, you put it as mild COVID. If the respiratory rate is more than 24 or it is mild tachypnea and the saturation is between 90 to 93, you put it as moderate COVID. And if the patient saturation less than 90 or respiratory rate is more than 30 or patient has tachypnea, you put it as severe COVID. So based on the COVID positive symptoms, you classify it as mild COVID, moderate COVID, and severe COVID. Why there is a column like patients could be positive but the symptoms couldn't be? No. Reason because many are being tested for patients who go through airports, patients who come to offices, students who come to schools and colleges, and any travel. All those people, asymptomatic people, also getting tested, out of which many are getting positive. So people could be COVID positive and they could be asymptomatic. So again, you put them into home quarantine. Here, another thing which is being done is patients, whether they are vaccinated or not vaccinated. So people who are not vaccinated, still having mild symptoms, you admit them into COVID care centers because you don't know whether they may have a worsening symptoms in later or not. And patients who are vaccinated, mild symptoms, you can give for home quarantine. And patients who are mild symptoms, vaccinated with comorbidities, you admit them into COVID care centers. So basically, the indications for admission is saturation less than 94. Patient who has a mild COVID disease. A patient who has a moderate COVID disease. Patient who are unvaccinated, or patients who are more comorbidities. Comorbidities in the sense here it is mostly diabetic, hypertensives, old heart disease, respiratory disease, liver disease, renal disease, and any disease, patients who are transplant recipients. So patients with comorbidities and who are having saturation less than 94, you admit them in the hospital. And patients, the last set of patients, which is severe pneumonia, patients who has an oxygen level less than 90 or the respiratory rate is more than 30, you directly admit them into an ICU or a facility where there is ICU available. So when it comes to classifying, as I already told you, there is mild disease, moderate disease, severe disease. A mild disease patient who are literally normal or oxygen saturation is more than 94 with minimal symptoms. What do we do, or how do we treat those patients? We have you call as polypharmacy or n number of drugs: favipiravir, ivermectin, vitamin C, zinc, ritonavir, indinavir, and molnupiravir. You can say n number of drugs. As of now, ICMR, WHO has clearly instructed none of the drugs are useful or they have proven any benefit in reducing the mortality, or they have not been proven in reducing the severity of the disease. So literally there is no point in giving all these drugs, but we are writing it just because of mostly for the placebo effect, or explain to the patient that okay, fine. And in simple terms, we can't say the patient that there is nothing, we can go back. I mean, we can't say that there's nothing possible or we don't have any drug. So we usually give them symptomatic management. If the patient has fever, a paracetamol. The patient has a running nose, an antihistamine plus a decongestant. Patient has some cough, or antitussives. So only symptomatic management with basic drugs is enough for a mild disease. But what now ICMR has suggested is patients who have more cough, or patients you think are having more respiratory symptoms, you can add an inhaled budesonide, either via an MDA or DPA at the dose of 800 microgram BD, mainly for patients who have more respiratory, that is, patients who have more cough. Otherwise, in mild disease, it is home isolation, home quarantine with very symptomatic management for 7 days. Earlier it was home quarantine for 14 days. Now it has been reduced to 7 days. In moderate disease, people who have mild hypoxemia, so you add oxygen. The preferred oxygen device is non-rebreathing mask, and try to put the patients on awake proning, and you can put in lateral position for 2 hours, awake proning for 2 hours, so in changing positions every 2 hours. And patients who require oxygen, that is saturation less than 94, you start them on IV steroids, basically either methylprednisolone or dexamethasone. Methylprednisolone is a very small dose, which is 0.5 milligram per kg to 1 milligram per kg in 2 divided doses, or you can give dexamethasone 6 to 8 milligram per day in a single dose. Usually give period of 5 to 10 days, but as long as the patient is able to take orally, the preferred route is oral compared to IV route. In patients not requiring oxygen, there is no role or no evidence of using injection steroids. So by giving steroids in patients not requiring oxygen, we are going to promote more side effects like a diabetes or increased incidence of mucormycosis, or the studies have clearly proven that giving steroids to patients who are not requiring oxygen is only worsening the disease compared to improving the disease. So indication for a steroid is very simple: patient requiring oxygenation. So saturation less than 94, start steroid. Saturation more than 95, no role for steroids. Anticoagulation, either unfractionated heparin or low molecular heparin. Only thing, it has started, whether prophylactic can be given or not is still a query. It is mostly to be treated based on case-to-case basis. It is better to do a D-dimer before starting, and if patient is having a D-dimer positive, it's better to start on a therapeutic dose. Otherwise, patient who is receiving only oxygen and steroids, start on a prophylactic OD dose. How do you monitor these patients? So clinically monitor them with the respiratory rate, oxygen requirement. So the most important feature is oxygen requirement. If the patient is having an increasing oxygen requirement, which means there is an ongoing severe disease, so which means he may progress badly. So we may have to add extra drugs, or we may have to increase the level of steroids. CT to be done only if there is clinical worsening, to make sure there is disease progression or to rule out any presence of pulmonary embolism. In this patient with moderate COVID disease, basically a moderate COVID pneumonia, you monitor them with CRP, D-dimer every 2 to 3 days, and daily you monitor with the complete blood counts, renal and liver function test. Renal function test because COVID per se is affecting the kidneys. So there are incidents of COVID AKIs, that is COVID acute kidney injuries, and COVID liver injuries, which are very common over a period of time. And with the drugs which you use, remdesivir has been known to affect both kidneys and liver. So that's why we'll have to monitor the patients for renal and hepatic parameters, either daily or alternatively based on the patient's condition. If the patient's baseline RFT LFT are normal, alternatively, and if the patient's RFT LFT are abnormal, prefer to monitor daily. Next is the role of remdesivir. Remdesivir, as per ICMR protocol, WHO protocol, all the protocols are clearly given. There is no role of remdesivir. Remdesivir has not proven for any mortality benefits or reduction in the hospital stay, but clinically we have been using it for a long time. And even when we discuss in our pulmonology groups, and most of our friends who we say that starting for remdesivir should be done for any patient who has oxygen requirement. So patient who has saturation less than 94, or who has more than 50 to 60% lung involvement. So usually we start them on remdesivir, and it has been shown to have some clinical benefit. So we don't have any data to say that, okay, remdesivir has shown to have a higher reduction in mortality, it has a reduction of hospital stay. But clinically, I think many of us will agree that remdesivir has its own benefits when it started early, and remdesivir should be started before 9 or 10 days. Like once the COVID has started, the COVID symptoms started and it is into the second week, after 9 days, literally there is no role for remdesivir. Next is severe disease. Severe disease, basically a patient getting admitted by ICU, and here it is mostly the use of non-invasive ventilators. Again, invasive ventilators the last priority, because we know that it is very difficult to intubate a patient with COVID, and it is practically very less number of patients come out of intubation. So we try to use NIVs most of the time, and HFNCs, which is high flow nasal cannulas, are used in most of the patients. But the problem with HFNC is it has a very high oxygen requirement. So the logistics of oxygen content, like a daily usage of the oxygen, is much higher when used in HFNC. So the craze with which HFNC came into the picture, it has lost the craze, because primary reason, not because it is not efficacious, it used a lot of oxygen requirement, whereas the simple bypass or NIVs were giving able to produce 90 to 90% of the same result with the lesser oxygen content. The problem with NIV is that because patients were not able to tolerate it, patients will tolerate HFNC slightly better, but HFNC, the oxygen requirement is too much. I think MSR will know, but we were facing it very difficult to meet the oxygen demands in patients who are using HFNCs. And again, when it comes to severe disease, use a high dose of steroids from 0.5 to 1 milligram to 1 to 2 milligrams in 2 device doses. And again, here, the next question is the use of Toleximab, which is the interleukin-6 receptor antibody. Toleximab can be used in patients who are having low oxygen saturation, and patients who have crossed 10 to 12 days of bed stay, patients who are on so many days of ventilator but still having a high oxygen requirement. Omicron, even for Omicron also, Toleximab is still working, because both steroids and interleukin-6 receptors don't work on the spike protein. So Omicron variant has only the problem, only the mutation in spike protein. So the other components are still same. So Toleximab still can be used for Omicron variant. Again, Toleximab still has its own side effects. Usage of Toleximab will increase the secondary infections. So it has to be used with caution, and it has to be used on case-to-case basis. And clinical monitoring, daily look for the work of breathing, patient's hemodynamic instability, and the change in oxygen requirement. And again, CT only when the patient has a clinical worsening. So, and all parameters have to be repeated daily. CRPs, DDMS, blood sugars, CBCs, LFT, RFT to be repeated and monitored almost daily. So who are the patients who are having risk of higher mortality? Age more than 60s, patient who have existing cardiovascular disease, hypertension, or other coronary artery disease, diabetes patients, immunosuppressed patients, patients who have active tuberculosis, patients who are existing chronic lung, liver, kidney disease, patients who have pre-existing strokes, and obese patients. These are the patients who have high risk for mortality. This list we know almost it is common for any disease. What one more point we can add is patient who had no vaccine prior or was only one vaccine. So vaccination increases the risk for mortality several folds compared to unvaccinated people. As we were going through the quiz, there are multiple new drugs which have come. One is Baricitinib. Baricitinib, the role is basically as an add-on therapy in patients who are getting remdesivir and steroids in the second week of patients who are on COVID treatment. Some studies have shown Baricitinib to reduce the number of days in hospital stay. The number of hours oxygen has been used. And again, Tofactinib is another drug. These are the drugs which have been used in some skin conditions and some immunological diseases. So they have some in vitro action on COVID. So they are trying in vivo also. Baricitinib has recently been approved by WHO for use in COVID. Still, it is yet to be included in our ICMR protocol. Sotrovimab is nothing but an IgG monoclonal antibody, which is used in the treatment of COVID diseases. It is again approved for usage of Omicron also, but it is still yet to come into our ICMR protocol. The recent drug Molnupiravir, it is supposedly an oral anti-COVID therapy. It has gained an importance because almost 30 to 40 companies have launched Molnupiravir in January after the recent approval. But ICMR has clearly given a warning because Molnupiravir has some teratogenic effects. So patients who are taking Molnupiravir should undergo contraception for the next 3 months. So this is a clear-cut red box warning which have been given by the ICMR. And as of now, ICMR has not added Molnupiravir in the treatment protocol for any of its guidelines. So Molnupiravir has its own warning. So which the Josh which it came but ICMR has given a warning, and we are still skeptical about molnupiravir, so we'll have to wait and watch. The biggest drug which was launched by Pfizer was antibody cocktail, which is casirivimab and India. It's basically the same spike protein antibody. It was given as an alternative to vaccinations. But here, because it is mostly spike protein antibody, they say this antibody cocktail is not as efficacious against Omicron as opposed to be against Delta. But still, it is still in the preliminary phase because it is only 2 months old. We need lots of data to say that. But what we know as of now is antibody cocktail is very good against Delta, but not as efficacious against Omicron. So though we know that Omicron is very mild, it causes lesser deaths. It is only highly transmissible. But this is yesterday's statement of our WHO chief. He says that we are in the much early stage, so it is still to be with more caution. And what stories we are hearing that it is caused lesser deaths and it's very mild could be misleading. The reason he says is that in a single number of days, the number of cases too high, it may collapse the healthcare system. In Delta, the healthcare system was collapsed because for lack of beds, lack of oxygens, and lack of the logistics. But whereas in Omicron, the healthcare system could be collapsed because the number of healthcare workers, including all the paramedical staffs, doctors from top to bottom getting infected with Omicron are much higher. Like we are hearing so many stories of every day at least 50 to 60 doctors to nurses getting it from a single hospital. Like for example, if in AVMC suddenly 100 doctors become sick, then it will be very difficult to manage an influx of patients. So which in turn will affect the patient care, and that could be a disaster even though the Omicron could be mild. So that's why as of now, though the transmissibility will be higher, the disease rate is much lesser in terms of death and the virulence is lesser, we are still has to be much more cautious and prudent, like how we were in Delta, even for Omicron variant also. So basically the only way to do is use preventive measures. We don't have any other thing. And another thing to use is an add-on to get the booster dose. Thank you. Thank you, sir.
Thank you, Dr. Madan Raj, for your excellent and very informative talk on clinical presentation and management of COVID-19. I fully vouch your statement that Omicron can completely collapse the healthcare system. As you said, every day we are getting positive reports for the healthcare workers, almost in every hospital. Even in Kadalur Hospital, Kadalur Government Hospital, some 10 to 15 doctors have become positive. And in our hospital also, many doctors are becoming positive, many staff nurses are becoming positive. And in most of the medical colleges in and around Pondicherry, the healthcare workers are becoming positive. Suppose if it goes in this rate, I don't know how the healthcare system will work in the next 2 or 3 months. I really don't know. But one consoling point is that though we get positive reports for the healthcare workers, so far in our campus itself, around 60 to 70% have become positive. But luckily, of course, all the cases are only having mild symptoms. No one, of course, so far even moderate cases we are not seen, and we are not admitted any patient in with that severity. That is, of course, blessing in disguise. And one question I just want to ask Dr. Madan Raj, in the triage protocol, what you have shown that RT-PCR positive. Is it a must that RT-PCR only should be positive, or even
Rat has
rat,
also
rat
even
can
RT-PCR
also be?
bar rat, sir. This is the government protocol, sir. So I just copied the same words, but even now they are given in their wordings also. Even if rat is positive, also it is to be taken as RT-PCR positive. Did not do
Okay.
RT-PCR for every patient, sir.
Okay.
And
Thank
one more thing,
you.
just to add on here, sir, because the symptoms are mild, even the isolations and the quarantine period have been reduced from 7 days from 10 to 14 days, because most of the people recover from 7 days. And actually, there is an hidden thing is that by giving 14 days, it is difficult for any company to keep up with the workforce, because if 20 to 30% of the workforce infected with COVID, like giving 14 days of everybody is really difficult. So government has come back with data saying that 7 days is enough for people who most of the people who have recovered. So that is one good thing, like by 7 days most of us can come back to work, and even if there is a high number of cases in our campus, like at least by another week, so most of us should be ready to take over the existing loads.
Yes, yes, yes. But though, of course, we get only mild cases, we'll keep our fingers crossed, because the WHO, what the WHO says is all variants of COVID-19, including Delta variant that is dominant worldwide, can cause severe disease, as you told, no? Severe disease or death in particular for most of the vulnerable population. So we need to keep our fingers crossed. Though many cases are mild, at any time this scenario can also occur.
And
Anyhow, thank you very much, Dr.
yes, sir.
Madan.
And even now also 15 to 20% cases are Delta. That is the
Um,
reason why we still get admissions, and it is still persisting. So that's why we'll have to be more careful, sir. And 100%
yes, yes.
cases are not Omicron. 15 to 20% cases even now are Delta in India, sir.
Yes, yes, definitely. The whatever case we get, we cannot consider all the cases as Omicron and consider that as mild. That can cause only mild problem. It can be even Delta variant infection, and we know the disaster caused by Delta variant in the last COVID 2 wave. So we need to be very careful, of course. Thanks, Dr. Madan Raj. And if any of the participant got any queries, you can just ask Dr. Madan Raj. We'll be ready to answer.
So we'll take up the questions at the end of all the sessions, sir.
Okay, okay, madam. Okay, then. Okay. Thank you, Dr. Madan Raj.
Thank you, sir.
And beloved participants, the widely used Rtpcr tests continue to detect infection, including infection with Omicron. Of course, studies are ongoing to determine whether there is any impact on other types of tests, including rat. Genomic sequencing is the only way to detect if a person who has COVID-19 contracted that infection from Omicron variant. But genomic sequencing is very expensive, due to which we are unable to do it for every single sample as and when it comes. It has to be done in batches of 24, 96, or 384. Testing 384 samples on sequencing. One sequencing chip costs around rupees 10,000 per sample. The cost becomes still more higher if the number of samples is lower. Further, only samples with a CT value less than 25 can be used for genomic sequencing. If the value is higher, it is tougher to get the full sequence, which compromises the accuracy of the results of genomic sequencing. The process of genomic sequencing takes up to 12 hours again, and subsequent analysis and manual confirmation takes another 3 to 4 days. These are the limitations in India, and of course, in developed countries, they are able to give the results still earlier. But in India, it takes more than 3 to 4 days for to give the results. But nowhere, even in developed countries, the result comes in a couple of hours, 2 hours or 3 hours. To highlight about the problems we face regarding lab diagnosis, as well as about the microbiological aspects of Omicron, we have with us our Professor Microbiology, Dr. Sethu Madhavan. I welcome Dr. Sethu Madhavan to give his talk on the said topic. Over
Thank
to
you.
Dr. Sethu Madhavan.
Thank you very much, sir. Thank you. Sir, I am audible now?
Yes, yes, sir. Very much audible.
Yes. Respected Dean Professor Kotur, sir. Dean HP Dr. Mahalashmi Madam. Medical Superintendent Dr. Jay Singh, sir. Medicine HOD Dr. Vityavadi Madam. AVMC Scientific Society Head and Dr. Deepa and her team. Senior faculty, junior faculty members. UG students and PG students. Good evening to all. Actually, Madam told us some 15-20 minutes. I will stop within about 10-15 minutes now. I will not take much time. And outside, I have to say thanks to the scientific committee member, this organizing team, for giving me this opportunity to share some few ideas about this pandemic viruses. So many things are discussed already by our Dr. Madan Raj, and he has helped discussion of all the things. Now we are aware that this coronavirus is a RNA virus. In our earlier textbook, it is given as only one paragraph. But after this pandemic, December 2019, volumes of informations are tons of generated, and almost all the participants and this listening members of this committee meeting, they are aware about much information. I am just adding little only. So there are various members are there. Coronavirus is a family, and coronavirus in that there are 4 things are there: alpha, beta, gamma, delta, and all. What currently we are that's facing the challenges by the Omicron. So earlier diseases which has caused severity is SARS 2003, then MERS 2012, and SARS COVID-19 is the current one. So from where does it has come that scientists are very much of talking that this animal, pangolin, bats have spread to this animal, and this animal it has jumped to human beings. So this is the structure of the virus. Single stranded RNA virus.
Sir, you want to share the screen, sir? We are not able to see the screen, sir.
Yes.
You shared,
Madam,
sir?
now it is okay, madam.
We haven't seen the screen, sir.
1 minute, madam. Now it's okay. Now it's okay, madam.
Viewing like that it is coming, sir. Screen here. You have started sharing, sir.
Yes.
Yes, sir. But, can you make it big screen? Can you make it a slideshow, sir?
Yes, sir. Yes, madam.
You cancel that, sir.
Cancel slideshow.
Can you make it slideshow?
Yeah, there only says slideshow is there next to animations.
Where, madam?
Top, sir.
Sir,
Top
home
ribbon.
animations in your PowerPoint ribbon.
Now it has come, madam.
Not yet.
So top home, insert, design, transitions, all are there now, sir. In that after animations we have a slide. Can you click that? I think Nishantini, you can help, no?
Madam. Sharing or not?
Yeah, we are able to see your screen, sir. We were able to see your screen, sir. Only big screen it was not seen.
Yes. It is now okay, madam.
Slideshow has not come, sir. Slide view is there.
Madam, you.
Slideshow, F5 or slideshow.
F5, madam.
So slideshow will be, the icon will be in the bottom somewhere here, sir. Just to search for it.
not changing.
Not changing.
Okay, sir, you proceed, sir. It's okay.
Yes, madam.
Oh, it has stopped sharing now again.
Just come.
Yes, sir. Yes, sir. Otherwise, you can
Okay.
please go ahead, sir.
Yes, madam. Madam, I am actually junior. Your
Changing.
changing. So this is the structure of this virus: helical symmetry, single stranded RNA. Main thing is that spike protein. What we are talking is about the spike protein. Madam, it is not moving. Huh? Ganesh? Not working.
Scroll. Change.
Yes. So we are having that we are talking much about the spike protein. That is the main thing. Actually, what actually has happened? This Delta virus spike protein and this Omicron spike protein, they are totally different. So the RT-PCR test, what we are doing for the Delta virus, that of course the spike protein cannot be detected in the case of Omicron. That is a thing that laboratory, what they are trying to find out, spike protein is missing. Then you have to say it is possibilities of Omicron. Spike protein, if it is present, then it is less likely that Omicron. So these various things are there, out of which we are concerned with the spike protein. These all the matters already we are aware about it. The receptor is angiotensin converting enzyme 2, more in the lungs. But presently, this Omicron, it is not going below the trachea. It is starting somewhere around above the oral cavity and causing this itchiness and throat. I believe that the severity already earlier speakers and MSR also told that we are not having much severe patient who needs admission and oxygen requirement and all. That problem has become less. But the number of cases is very high because these viruses have changed itself that how to enter the cell by doing the mutation in the spike protein. Now these type 2 alveolar cells are highest in the lung. So for this maybe this spike will peak will go very high in the January last week and February also. But by March 11th, this pandemic may end. That is what these international scientists as well as our ICMR high-level people are also telling. March 11th, that is what the date they are telling, provided there is no other variant is gaining upper hand. And this Omicron probably it has come only to help for boosting our immunity so that the Delta and other variants, everything will not create any more problems. So it will remain as a flu for a long period and we have to live with them. I think that we are in the pandemic, that end stage has come. That's what the scientists are telling. So these all the details we are aware that the virus enter and then creates the multiplication and all and comes and all the things. This swab and all we are taking in the specified area where all these personal protective equipments, everything has been done and spread is minimized. So these are all some of the equipments required for this virus sample collection and all. Now, the most important thing is that the real-time RT-PCR we are doing. All the laboratory they are having the machine, very costly machine, some 15 lakhs or something. But the kit actually that now there's a new kit has come, Omicron. This Omicron is prepared by Tata Medical Diagnostic, and the head is Dr. Ravi, who was earlier the director of this NIMHANS, Bangalore, and ICMR has given the approval for that. So this particular kit, MSR already told the Omicron number 1152.9. That is the number 1152.9. Delta variant is 1617.2. Delta, of course, Mother Teresa told as I think 80% Omicron has come and the Delta variant number is reduced to 20%. I think that till March, the Delta may slowly come down. So Omicron will gain more. So almost everybody is going to get infected with the Omicron. And other thing is that those who have received the vaccination, the immunity will be very strong. So that what happens, this Omicron will have some effect, definitely. And at present, all these precautions plus this vaccine, that is the only way by which we have to further move. So transmission is very high, virulence is very, very less. As even that South Africa, that first reporting doctor also mentioned in her case that all the patients who came, the severity is very less. And diagnosis part, now we are having the homemade, we can say that in the whole world, first time this in India, this Omicron detection kit has come. It is only about 250 rupees. As Sir Sir told that genomic analysis 6,000 to 10,000 price it cost, and 1 week time they need. It is not possible for our country that genomic study and all. But this 250 rupees kit that will work even in the all the real-time PCR machine which our laboratories are having. So we need not have any extra investment. Vaccine definitely that immunity which of course the spike it has changed, but the rest of the things are still under the control. The cell-mediated immunity also will play a role. These are all the things that discussed. And what we have to do? We have to do the Rtpcr testing. Existing, there is a kit is there in that year. 2 genes they are detecting, but the third one is new kit is having the S gene detection. If S is coming, then it is not Omicron. If S gene is dropping, it is failure, then it could be Omicron. Whole genome sequencing that already we have discussed. This is a company, Tata Medical Diagnostic, Omicron. This kit cost is 250 rupees. It is approved by the ICMR. It is sensitivity, specificity, everything is checked by NIV, that is National Institute of Virology, Pune. So this approved kit, I think it is available now in the supply. It is using both mechanism, that is dropout, that mechanism also is there in the first step. The mutation amplification also is being detected. So I think that this definitely all Omicron patients, this Omicron kit can be made use of because of the cost effectiveness. And that ICMR chief also told that it is working well and that particular batch number. So further this quality will be maintained. And all the other things are there. I don't want to take much time. So what is my conclusion is, there is a kit by name Omicron. The price is about 250 rupees. It is prepared by the Tata Medical Diagnostic, and the head is Dr. Ravi, who is a neuromicrobiologist who worked in the Bangalore NIMHANS. He was earlier genome sequence head in Karnataka, and I think that is our ICMR as well as National Institute has approved this kit. Very soon, this Omicron will help us to end the pandemic by the March 11th, as per the scientist announcement. Thank you for giving me the opportunity to be in front of you. Thank you, sir.
Thank you, Dr. Seth Mathavan, for your sharp, short and sweet talk. One question is, sir, is it available in the market, sir, that kit what the Tata this thing is developed? Omicron, is it available now?
Yes, sir. Actually, January 12th it is released.
Okay, okay. Oh, then we can procure for our
yes, sir. Yes, sir. Yes, sir.
Lab also,
yes,
sir.
Yes, sir. Bulk quantity, many states have already put order. So I think that we also can think of getting for our things, sir.
Okay, okay.
Thank you very much, sir. Thank you. Sir.
Thank you, thank you, thank you. So we will move on to the next topic. Despite unprecedented lockdowns, movement restrictions, social distancing measures, stay-at-home orders enacted by many countries during the COVID-19 pandemic, caused devastating morbidity as well as morbidity. In spite of all these measures, lockdowns, movement restrictions, stay-at-home orders, in spite of all these measures, the COVID-19 pandemic caused devastating morbidity and mortality. The vast majority of the global population remains susceptible to COVID-19. highlighting the need for an effective vaccine. Of course, since the drugs were not available, we were very much in need of some effective vaccine. The global vaccine development efforts have been accelerated in response to the devastating effects of COVID-19 pandemic. Of course, some vaccines, of course, they have formulated, they could get. The studies made so far with regard to the vaccination and efficacy of the vaccination, the studies made so far show that vaccination can have a substantial impact on mitigating COVID-19 outbreaks, even with the limited protection against infection. Vaccination reduced the overall attack rate to 4.6 from 9%. 4.6% from 9%. 9% has been reduced to 4.6 after vaccination. The highest relative reduction around is around 54 to 62% was observed among individuals aged more than 65 years. Today, to throw more light on the impact of COVID vaccination on population, we have with us our member secretary, associate professor community medicine and a vibrant COVID nodal officer, Dr. Nishantini, to give a talk on the impact of vaccination on population. Welcome, Dr. Nishantini. Over to Dr. Nishantini.
Thank you, sir. Good afternoon, respected Dean, sir, respected Medical Superintendent, sir, respected Dean, HP, ma'am, other HODs and faculties, my dear students. Good afternoon, all. I thank the Scientific Society for giving me this opportunity to speak on this impact of COVID-19 vaccination in population. Ma'am, my screen is visible, ma'am?
But you can make
Visible,
it a
not
slideshow.
in
Slideshow.
slideshow mode. Make it slideshow, please.
Yes.
My topic is impact of COVID-19 vaccination in population. So the session objective will be to discuss the challenges and impact of COVID-19 vaccination. Framework of my presentation is this, starting with introduction, vaccination status, and lastly from lesson from Israel. So to start with the introduction, to go back some 2 years behind, timeline of COVID-19 is in first case of COVID was reported in December 2019. And in January 30, WHO declared COVID-19 as a public health emergency of international concern. And in March 11, 2020, COVID was declared to be a pandemic. And up to date, till after 22 months, even now, we are at the third wave. So starting from first wave, and in other countries, they were giving vaccination in mostly around November 2020. But in India, we started the vaccination in 21st January 2021. So then after that, in April 2021 till May 2021, we had the second wave. Then from January 3rd, the third wave has started. And what are we doing? So here, if you see the worldwide, high-income countries have increased the availability of vaccines than the low-income countries. So though the availability of vaccine is more, but the acceptance of vaccination is very less among the high-income countries compared to that of the low-income countries. So if you see here, only 6.8% of the low-income countries, that is that much percentage has been fully vaccinated. But to go ahead, India, it is very much good in vaccination. That is till 18th of January, we have set a world record of 2.5 crore vaccination in a day. That was doses in a day. So this is a vaccination status worldwide. That is total doses given worldwide is 9.75 billion, whereas in India it is 158 crore, that is 1.5 billion. And those who are fully vaccinated were 392 billion actually, that is. And here it is 3.92 billion. Here it is 65 point, in India it is 65.9 crore. And percentage of population who are fully vaccinated is about 60.1% worldwide. India, we stand for 47.7% who were fully vaccinated. This fully vaccinated, it is only with regards to the 2 vaccinations. And booster dose, we are not yet considering. Here, the booster dose given is about 0.3% till yesterday. So this is a vaccination status. And regarding the vaccines in India, as you all know, we have a Covishield vaccine, a Covaxin, and a Sputnik vaccine. Apart from that, we have another world's first DNA vaccine, which has been approved by the national regulator. And apart from that, we have three another vaccine that is manufactured in India. That is one is a viral mRNA vaccine, one is a subunit vaccine, and by Bharat Biotech, that is Covaxin, the group which has been manufacturing Covaxin. The same group is manufacturing is in the verge of approval, that is intranasal vaccine for COVID. So this is a comparison between the Covishield and Covaxin. So this issue previously, when we were given first dose in January, January it was like 4 to 6 weeks. And later the dose interval has been changed, that is 12 to 16 weeks. And efficacy of the vaccine, this was 90% and 81%. But when compared to that of the Pfizer and Moderna, which was nearly 97% and 95.6% somewhere. So the breakthrough infection. But the breakthrough infection means the infection which has been acquired after prophylaxis. That is, once a person has been vaccinated, after vaccination, if a person has been infected, then it is said to be the breakthrough infection. So in among Covishield and Covaxin, Covaxin was highest, that is 0.04% has got the breakthrough infection. So then what are the challenges in vaccination as such in vaccination program? So we had a political challenge, that is manufacturing the drugs and distributing, timely distribution of the drugs. Financial problem is there. Then programmatic management, the to whom the drug should be, to whom the vaccination should be reached. Then a technical issue at timely procurement of the drug. Then operational, then epidemiological, that is we need to go in for research, then the financial constraints were of concern. These were some of the challenges in conducting the vaccination program as such. But apart from that, we have certain challenges during vaccination itself. That is vaccine non-accessibility. That is, though we have received, that's what I was saying, Covishield, we had that initial phase, we had only 4 to 8 weeks of interval, but there was information that due to vaccine non-accessibility only, they have increased the duration like that. So next was vaccine hesitancy. The beneficiaries themselves, they are hesitant due to the doubt that whether the vaccination is efficacy of the vaccination, safety of the vaccination. So because of that, there was a hesitancy among the beneficiaries. Then misinformation regarding the vaccine. It was mainly through the social media that various misinformation regarding the vaccine, which pose a challenge for the beneficiaries to get their vaccine, to get vaccinated. Next, about the breakthrough infection, which I told already, and this is of very much concern. That is, even after vaccination, when a person is being tested positive, means that was of great concern, the challenge in the vaccination campaign. And yet another thing, once a person is vaccinated, they think they are safe, and there are much more breach in the social distancing and wearing of masks. So the relaxation, they have come to that relaxation mode. Once they have vaccinated, they have come to the relaxation mode, thinking that they are very safe. And so this was also one of the challenges. So what was the reason? There was a lot reason why they are not getting vaccinated. That is efficacy of the vaccine, safety of the vaccine. They do not believe why they need it, and they don't trust the vaccine which has been manufactured by the pharmaceutical companies. So these are some of the reasons for not getting vaccinated. And what was the factors for breakthrough infection? Why am I concentrating towards breakthrough infection is after vaccination, this breakthrough infection was of great concern. But this breakthrough infection has a very important advantage. That is, once a patient is infected and if they are getting the infection, that infection is acting as a booster shot. So that was one finding which they have found in which was found in the literature. And so what are the factors affecting this breakthrough infection? Means the amount of virus in a vaccinated person once they're exposed to the particular virus. Then what is the antibody that is being produced, level of antibodies that is produced in the body, and affinity and avidity of the antibodies to the circulating variant. So these three factors, though these three factors are not easily measurable, though they are not easily measurable, that has posed a very much great challenge to acquiring the getting the vaccination. So advantage as such, when we say about the advantage of this breakthrough infection, CDC report says that about 25% to 30% of the patients who have had the breakthrough infection are completely asymptomatic. So asymptomatic, they are completely asymptomatic, and some percentage they had only mild symptoms, and nearly hospitalization and death were very minimal. So one advantage, as I told earlier, this breakthrough infection is likely to act as a booster shot to a individual who has received vaccination. So what about the vaccinated versus post-infected person? That is, a person is vaccinated and another person is there who's after the infection, who has acquired the infection. So if you compare them, though the antibody level in the vaccinated individual is less by 20% compared to that of the person who has been post-infection, the protection against symptomatic infection is 50% high in the vaccinated, among the vaccinated individuals compared to that of the post-infection individuals. So though the antibody levels, what I mean to say is, though the antibody level is much lower, the protection is higher in vaccinated individual. So again, when compared to that of the severity of the disease, this antibody level doesn't fall to 50% until antibodies wane to just 3% of post-infection level. When the after post-infection, when the antibody level is going to be below 3%, which when it is going to come to below 3%, then only there is going to be there will be fall in the antibody by 50% in the post-infection level. So this is to do with the vaccinated and post-infection. Next, there are various studies which are giving both positive effect and also negative effect towards vaccination. And among that, this is one study which gives the effect of COVID-19 vaccination in Italy and perspectives for living with the virus. So what they have found is, among the natural protection, this green color is a natural protection and this gray color is a vaccine-induced protection, and this red color or pink color might be it's a fully susceptible person with fully susceptible. And if you see the estimated proportion, the proportion is likely to be higher among the vaccine-induced protection. So at all age group, if you see, so 0 to 19 and 10 to 19, there in Italy, their age group of vaccination was only above 16 years at that time when this study was conducted. So only this vaccine-induced protection is much lesser. But when you compare with other age group, this vaccine-induced protection is much higher compared with natural protection and fully susceptible group. So what about this Omicron? We are talking about Omicron and the booster dose of COVID-19. So this is one study which says, though Omicron is having a higher R naught, you all know that R naught means it's a reproduction rate. Reproduction rate means the how much the disease will be transmissible. The transmissible rate is said to be the R naught. Though this R naught is 10 for Omicron, this severity and its severity and hospitalization is very less in Omicron. So what happens in case of COVID-19, those who have got vaccinated? So what this particular study, it is not a study actually, it is a review article. This review article says that T cell responds to the whole of the spike protein. Though there may be many mutation, but still this T cells will identify the spike protein, so they are less likely to be bothered by a few mutations. So it is possible that Omicron will be easily identified also. They probably play a part in preventing severe disease, though we do not yet know how big a part. In severe, it was told already, previous speakers have told that in severity of the disease has been reduced, but how much it is going to reduce, that we don't know. So the vaccine effectiveness data might indicate that Omicron does not significantly increase the risk of severe disease or death in vaccinated population. So this is one review article which gave the information that vaccine previous coming data might give us evidence how much vaccination is giving protection against this Omicron. So there are a few other studies also which says there is one study which compared among the vaccinated and unvaccinated individuals. So in that study also, that incidence rate was higher among vaccinated people compared to that of the, incidence rate of the disease of COVID-19 was higher in unvaccinated people compared to that of the vaccinated people. So this was a study from NEGM article. And this one study which I want to quote, the epidemiological relevance of COVID-19 vaccinated population is increasing. This is one study which says that this disease as such is transmitted through vaccination only. Only this I have seen this article saying that this transmission of disease, because they have compared the secondary attack rate among vaccinated and the secondary attack rate among the unvaccinated people, what they have found was that there was no much difference among the secondary attack rate. From though the index case was also a vaccinated person, and that index case, a secondary attack rate to those who acquired the disease, those people were also vaccinated people. So this particular study says that there is no much difference in vaccinated person and unvaccinated person for acquiring the disease, but the same study does not say about the severity, how much is the severity. They're just saying that it is increasing the disease, transmission of disease is through the vaccinated population, but they are not saying about what the, they're not saying about the severity of the disease as it. So this table, actually this graph, it indicates the proportion of fully vaccinated people among symptomatic COVID-19 cases above 60 years of age and vaccination rate. So it was all the same only. So apart from that, one good study which has given a positive effect towards vaccination, that is Israel. As we all know, it was one of the highest, country with highest vaccination rate in the world. That is almost 80% of the population above the age of 12 years has been vaccinated. And there, after vaccination, during the third wave, there was, before the third wave, when there was a decrease in the cases, what they have done is, due to this vaccination, high rate of vaccination, there was relaxation in the social distancing measures. So that has made the flare up of the cases, that has increased the cases. But that part of Israel, Israel also, that study also says that current immunization rate, the vaccines appear to be nearly 70% effective at preventing hospitalization. So this was one conclusion that was given by that study which was made in Israel. So we have another one one negative feedback about the vaccination, one study which was published in Lancet itself. So they also say that vaccination is not protective against COVID-19, but to the consensus, we are suppose, as I told, that breakthrough infection will be a booster dose. So similarly, for the identification of the T cells to identify boosters, booster dose is a must. So it's better to get fully vaccinated and also go in for booster vaccination. And we increase the vaccination coverage among those who are most at risk in all countries. We also have to take the steps to drive the transmission down. So to decrease the transmission, to decrease the rate of transmission, better we have to increase the vaccination coverage. And to reduce, apart from that, increasing the vaccination coverage, you have to reduce the risk of exposure to the virus, whichever variant, whether it is Omicron or Delta or Alpha variant, anything, whichever is a variant, we have to reduce the exposure to the virus. We may not think that we are vaccinated and we can be relaxed with the physical protection, with our personal protection, but that is not the thing. But though we are vaccinated, our exposure need to be reduced also. So with this, I end my session. Thank you all.
Thank you, Dr. Nishantini, for your very elaborate talk. Now I think it's time for the questions to be asked to the speakers. Now it's already 4:25, so we'll minimize the questions. First, if there is any question for Dr. Madan Raj will be ready to answer. Anybody wants to ask anything to Dr. Madan Raj, please ask.
Sir, there is a question in the chat box. If the Madan sir has proposed that the vaccines have got a efficacy of only 5% against Omicron, but then why is the treatment algorithm focusing on vaccination status for admission in the algorithm which you have proposed, sir, the triage?
The main reason, because even now also Delta is still forming around 20% of the cases. So in unvaccinated people, the presence of Delta vaccine is having a very high mortality. So that's why we are concentrating on unvaccinated people. And though the vaccine efficacy is only less than 5%, with the advent of booster, the efficacy is increasing up to 60 to 70%. I think that's what Madam President. So adding a booster, there is a high efficacy rate. So and we have more data saying that the mortality in unvaccinated people is much higher compared to vaccinated people. So for epidemiological purpose also, so we'll have to separate vaccinated and unvaccinated people. That's why the Triage Protocol is concentrating on the presence of vaccinations.
Thank you, sir, and thanks to Dr. Nishantini for evidence-based campaign for the booster vaccination. Because in spite of us conducting vaccination camp in our hospital, the booster vaccination number was still low as per the number which we have seen for the past 4 days when we conducted the camp. Thank you, sir. I have one question from my side. What is the role of CT value, which is given in RT-PCR report of some labs in managing the patients with COVID? This is a common question I'm getting even from some of my patients or their relatives. They'll be getting the report with the CT value.
CT value is nothing but turnover rate, ma'am. I'll keep it in a very simple way. The lower the CT value, the higher the severity of or higher the viral load inside the person's body. It is approximate. Okay, which means, like say for example, CT value is 15, which means within every 15 minutes the virus will become double. If the CT value is 25, every 25 minutes the virus will become double. So like if the CT value is lower, you will have a higher viral load. If the CT value is higher, the viral load is comparatively lower. It is just a rough way of explaining. So I'm not going into the exact microbiological data in between. To say in for any plain patients or attenders of yours, you can say lower value, higher infection, higher value, lower infection. As simple as that, ma'am.
So your management algorithm is not going to change with the CT value.
No,
Is it?
management algorithm is not going to change based on the ratios. Earlier, initially, they were looking for neutrophil lymphocyte ratio, like multiple parameters to say, based on this parameter, the severity is more. Based on this parameter, the patients were more going in for ICU admissions, more pneumonia were forming. Out of like so many data like neutrophil lymphocyte ratio, higher CRP levels, interleukin levels are higher ferritin levels. So this CT ratio was also one of the parameters which was seen. But later it was proved that, okay, this is not the exact parameter. So we are now following it, but we are not actually bringing it to any protocol for managing or even for classification of severity. Also, we are not using it in any protocol. It is mostly a epidemiological data. We can use it for research in future.
Thank you, Dr. Madan. And I saw a few investigations only you have put forth for the management of COVID. A few investigations you have taken out, like last time when we are doing serum ferritin and CRP, all those things. You have not included those investigations. Hope so in our next protocol we'll be doing only these investigations in the forthcoming wave when we face the patients.
ICMR has clearly given like polypharmacy, poly investigations, polymedications to be avoided.
Okay. Okay. Thank you, Dr. Madan. So in the
Any
chat
questions?
chat
Any
box, we
questions?
don't have any other questions, sir. So anyone
Okay.
want to ask also, they can ask.
Okay, then we'll wind up the scientific session, madam. Thank you. I once again thank our scientific team for giving me this opportunity to chair the scientific session. Thank you. Thank you all.
Thank you, sir. Thank you very much for chairing this session. And I thank all the resource persons who have accepted and who have highlighted the very salient points which we are in need now, need